Once again, yeah, good evening, everyone. Good afternoon, good morning from wherever you are, and thanks for joining in our bi-weekly sessions. Again, thank Dr. Balthazar for joining. Hopefully, Dr. Mankad will join us shortly. I think we have around 10 cases with one follow-up case, so we'll get right away. Please feel free to use the chat for your comments, for your any questions, queries that would be helpful. So we'll start off with case number 1. Over to you, Anas.
Born to non-consanguineous parents and had no perinatal or postnatal complications with normal development premorbidly. He presented with multiple episodes of seizures in the form of uprolling of eyes and tonic posturing lasting for 2 minutes. Required multiple anti-epileptics. On examination, he was awake, aware. No focal deficits on examination. But in view of recurrent seizures, imaging was done.
All right. Okay, I have only film images. Apologies for slightly pixelated, blurred images. But Anas, at what time period was it done? Was the scan done from the clinical symptomology?
So he came to us on day 4.
Day 4. Okay, scan done on day 4 of symptoms.
Yes, 7th they had come. 7th he had the seizure,
okay.
And he came to us.
All right. Okay.
Day 4, day 5.
So I have diffusion panel over here, and you can appreciate. I'm not sure if you can clearly appreciate, but here you can see that there are areas of restricted diffusion in the bilateral frontal regions. If you see the lower panel, predominantly involving the cortical regions. While coming down more inferiorly, you can see that there is basal ganglia involvement. At this image, the right basal ganglia is more predominantly affected in comparison to the contralateral side. Coming more inferiorly, I do not see any other areas of ischemia or infarct. So the primary changes were areas of cytotoxic edema in the bilateral frontal lobes and also the right basal ganglia, and possibly a focus over there in the periventricular region on the right side. Again, slightly blurred images corresponding T2 sequences. Nothing new to add than what we have seen on the diffusion weighted sequences. So bilateral subacute ischemic changes in the frontal lobes and also involving the debrei nuclei. So based on that, I don't have the angio or any vessel wall images.
Stroke. Actually, thing is, he had no. I mean, he was quite asymptomatic. The MRI was quite. I mean, we were not expecting it to be that way. His hemoglobin was 8.5. Platelets were normal. Coagulation and homocysteine others. Workup for stroke was negative. 2D echo was also normal. Genetics was sent, which later we were thinking in line of some congenital moya kind of thing, and whole exome sequencing showed ABC C6 mutation, that is a pathogenic variation. Homozygous mutation was found. So again, he was taken up for surgery. Revascularization was done on right side, and so far he's quite asymptomatic.
And any other clinical systemic findings supporting the gene?
2D echo, we had, I mean, they have reported that some kids may have the cardiac dysfunction and heart failure, hypertension. But in our case, they did not have urinary calcium creatinine ratio was done as well. Endocrine opinion was taken as well, but there was no other findings as such. But it's quite early in the stage. Maybe we have to keep him on follow-up to see how is he doing. Okay. So right now, so far, nothing other than the stroke that he had.
All right. Yeah, I'll open the case if anyone has similar experiences with that gene and any other systemic involvement and the prognosis.
I have no experience. I just wonder, am I right? You have made the diagnosis through this. You had no clinical suspicion.
Yes, no clinical suspicion.
We were looking for collagenopathies. And this is a gene which is known to be associated with vascular abnormalities, extensive, and in fact, they can cause myocardial involvement very early in life and death as well, myocardial vascular involvement. And extensive vascular calcifications are also noted with this gene. So you are looking for something affecting the blood vessels.
Thanks.
Even-
Okay.
aorta no calcification
So,
found elsewhere.
Okay. I don't think we did a CT.
Uh,
All right.
child
Um,
follow-up and endocrine as well as neuro follow-up is being done for the child.
Okay. Okay. All right. So just a question, Dr. Lokesh, revascularization without, do we do it on the first event itself? Is that known for this, for the bilateral involvement?
Yeah,
or-
so yeah, because you do not know when the next episode is going to
Yeah.
happen, and each episode is going to take a lot of part of your neurons. So we do revascularization very early. That's the only way you can preserve the existing brain matter.
Got it. Okay, then we'll move on to our next case then. Devangna, over to you.
This is a 7-year-old child who was brought to us with history of not restricted eye movement of the left side since 7 to 10 days prior to this episode when she had presented to OP. Otherwise, she doesn't have any other history other than just restricted eye movement and left eye ptosis. There was no associated fever, headache, lethargy, altered sensorium, or seizures. Cranial nerve examination wise, there was direct and consensual light reflexes on the left side was sluggish, right side was normal, and there was left eye ptosis with mild proptosis, and there was extraocular movement restricted in all direction. Otherwise, tone power was normal, deep tendon reflexes were normal, there was no cerebellar signs and no meningeal signs. She was walking normally and there's no signs of raised ICP. So we had a localization of could be cavernous sinus or superior orbital fissure syndrome. So initially she had come to us with CT, and then we got the MRI done. So,
Okay. So this is the initial CT. I have non-contrast CT, and as you can see, there's some thickening of the paranasal sinuses, the maxillary sinus over there on both sides. Also, yeah. So these were the only images I had. So predominant involvement of the maxillary sinuses. The ethmoidal ASLs, the sphenoid sinus was relatively clear, at least on the first CT. Yeah. Then the course, Devangna, you did an MRI immediately after the CT.
yeah, we did the MRI after the CT. So the first MRI, can we see?
Okay. All right. These are again external images, so again slightly pixelated, but the MRI on top, you have the T2 fat side sequences. And now you can appreciate that there is some ethmoidal ASL involvement, sphenoid sinus involvement, and also the cavernous sinuses on both sides are not suppressed. They are demonstrating hyperintensity, and they're slightly bulging out, at least the lateral wall on the left side, and also extending up to the superior orbital fissure on both sides over there. Coming more inferior, again, the maxillary sinuses, extensive involvement on both sides. And on post contrast, you have this, at least on these images, homogeneous involvement of the cavernous sinuses going up to the proximal optic nerves, the superorbital fissure. And again, better appreciated over here on the current sequences, you have this homogeneous involvement of the cavernous sinus going up to the suprasellar region, also involving the stalk. So these were the second MRI findings, or the MRI after the CT. And there was a follow-up MRI. Anything to add, Devangna, in between?
Yeah,
And the
after
time.
this MRI, we took a ENT consultation, and after the ENT consultation, they went ahead and they did a debridement of the nasal sinuses, endoscopic nasal debridement of the left ethmoid and sphenoid sinus, and the tissue extracted was sent for HPA microscopy and culture. So we got a call next day from the microbiology department. They have prepared a wet mount, which showed. So can we see the video?
So I have a follow-up. Yeah,
Play?
okay. So I have the follow-up MRI at our center again. Again, just additional sequences, the diffusions over there. The cavernous sinus abnormality demonstrates heterogeneous but internal areas of restricted diffusion. Also, you can see that the proximal optic nerves on both sides demonstrate restricted diffusion. Supracellular components also here on the stellar sequence, you have the stellar involvement, supracellular involvement involving the stalk. So now it's more of a heterogeneous signal on the T2 weighted sequences as compared to the first scan with some areas of restricted diffusion. Post contrast, again, intense enhancement, but some degree of heterogeneous enhancement, extending up to the superior orbital fissures, the proximal optic nerve. stellar, suprastellar components, also involving the clivus over there and the retroclival area, the S3 and the superior aspect over there. So this is the follow-up scan. I'll just get back to that, but yeah, Debanga.
There is a video.
Video.
Yeah, there's a video. You want to biopsy? Okay,
Yeah.
the biopsy was done and
Yeah, so biopsy, wet mount preparation, and culture sensitivity was sent for. So the
Okay.
video was showing. So again.
Yeah.
So this is a wet mount preparation, which is showing a free living amoeba in the wet mount, which is the moving thing can be seen. So it was possibly, it could be a Balamuthia or a Naegleria fowleri cavernous sinus infection was the possibility.
and nothing to narrow it down between both of them.
So no, because we cannot differentiate on the
Okay.
wet mount preparation. So for differentiation, we need to do a PCR or whole next generation sequencing, which is done outside India, but we could not found
Okay.
in India. It is not done anywhere, sir. So we wrote a mail to CDC, and based on the treatment of all the survivors of this infection, they gave us a treatment plan consisting of IV pentamidine, sulfadizine, fluocytosine, fluconazole, miltefosine, and azithromycin. But pentamidine is not available in India, and we could not find miltefosine as well. But we started off with other medications. She initially improved, and the other scan was done after a period of around a week later. She had gradually improved. The clinical condition had improved, but there was extension shown in the MRI.
All right. So this is the last MRI we saw, and then we had a follow-up MRI. So this
Yes,
is the follow-up MRI. Just to add, there was optic tract involvement of the optic pathways extending up to the hypothalamic region. Also now demonstrated these hyperintense edematous changes. Supracellular component also had increased progress in comparison to the first scan, better demonstrated again on the contrast sequences. So optic pathway involvement was has progressed on both sides. The optic tracts, the hypothalamus, memory bodies are involved, and the supracellular component also increased in compared to the previous scan. The cavernous sinus portion was relatively stable, but there was more extension into the supracellular and the optic pathway structures. There's also some hemorrhagic component over there in the supracellular component, going up to the median eminence and the optic and the pituitary stalk. Yeah, so I'll open the case now. If anyone has any similar cases, or any comments to pass on the imaging and the diagnosis on the wet mount condition.
Actually,
So,
current update is she's all. What? Sorry, Vivek, you go ahead.
So they from PGI they published a paper last year doing a PCR. They have a panel for free living amoeba, all three of them. Dr. Adodra, you can contact. So there they can do to differentiate between the three. So there was like 149 CSF samples, of which 12 had the free living amoeba. Right.
Yeah, actually,
So
our microbiologist spoke to them.
Right.
Currently, they had some issues, so they didn't. They said at this point of time we are not able to do because he communicates with the PGI microbiology lab because that's a reference lab.
Right.
Yeah. So currently, almost 1 month into treatment, her creatine has increased to 3, and she has become drowsy now. It has spread on to other eye. The eye movement abnormalities have spread on to other eye. She is in a different center now in their local place. It is progressively worsening actually, instead of all the treatment.
All right, I don't think we have any comments. Yeah. All right, thanks, Tamagana. Thanks, Dr. Kesh, and thanks, Dr. Vivek. Dr. Vivek, over to you.
Thanks. These are two really interesting cases. Not sure we'll ever see again in life or see. Oh, that's great. Keep those as differentials, especially for cavernous sinus thrombus. One needs to have a really good microbiology lab to pick these up. Microbiologist, sorry. So this is a 5-month-old baby who has had significant failure to thrive, doll species. So just 3.54 kg baby with hepatomegaly and central hypotonia who had come to my gastro for evaluation. And she also had these skin lesions, which was diagnosed as atopic dermatitis, but always leave a hypopigmented area once they would resolve. So initially there will be some redness, and then when it resolved, there will be these hypopigmented lesions, which won't follow any dermatomes or blushful lines. It was on both sides. And if you see this, the hair, there is no hair loss. They had the hair removed. So, but she does have sparse eyelashes and sparse eyebrows. She had hepatomegaly, and her evaluation had shown deranged liver function with slightly raised ferritin, 700, and normal, slightly deranged coagulation. So there was evidence of liver dysfunction with hepatomegaly. So she had a MRI done subsequently, which Nihaal, do you want to discuss?
Yeah,
we
so
did
then-
do,
yeah.
I would just rest TMS, GCMS, biotinidase was normal. And lactate was just mildly raised. Our values are 20, it was 24. Ammonia was normal.
So MRI at 4 months of age, and you can appreciate straight away there is a reduction in the periventricular white matter volume. You can see there is some scalloping of the lateral ventricles. The corpus callosum is thin. You can better appreciate that on the coronal, the sagittal sequence over there. And there's also a degree of pontocerebellar hypoplasia, particularly the inferior cerebellar hemispheres over there. The vermis is hypoplastic. Also, the pons itself is demonstrating some degree of hypoplasia. So I would say on these images, there is periventricular volume loss, hypoplastic or thinned out corpus callosum, hypoplastic brainstem and pons and cerebellum. No structural abnormalities. For a 4-month child, I think that the myelination is all right. The posterior limbs are myelinated. The anterior limbs are almost starting to myelinate over there. So yeah, these were the main findings, at least on this these sequences. And then the diffusion weighted sequences demonstrated these symmetrical areas of vesicle diffusion, predominantly along the corticospinal tracts going up to the pyramidal tracts. So there, the bilateral plex, the pyramidal tracts, the optic radiations on both sides. Subthalamic nuclei again has the symmetrical changes, and the pontocerebellar fibers, the brainstem tracts, the central tegmental tracts demonstrate the symmetrical area of restricted diffusion. So in addition to the structural changes in the T2 weighted sequences, these were the additional changes on the diffusion weighted sequences. As Dr. Vivek has already mentioned, that there was some derangement of the liver function, the ferritin and triglycerides were mildly raised, TMS, GCMS was normal, blood lactate was slightly high, and there was normal ammonia. Given the predominant or very significant skin changes, this was a paper that for atopic dermatitis, which was mentioned in the clinical presentation, and in the infants, these were the various differentials one can think of for the cause of atopic dermatitis, which leads on to hypopigmentation. So yeah, genetic disorders, immunodeficiency related disorders, and nutritional disorders can cause these changes in the skin. And if you look at the MRI changes, these are the various differentials. Spectroscopy wasn't done for this child or wasn't available, but the symmetrical changes along the corticospinal tracts, pyramidal tracts, these are the various differentials. Just tying in the clinical information, I thought of a possibility of biotinidase deficiency if it matches to the skin changes or not. We'll just get to that. Piga A can have liver dysfunction. And the other one I thought was the phenylketonurias, which can have these periventricular changes. I don't have an image out there, but whether eczema or atopic dermatitis is a common feature in infantile age group and which corroborates with other clinical parameters is the question now. So yeah, I'll open the case if for others to now comment upon that. I'm getting in chat biotinidase, homocystinemia, LCH maybe, yeah, NKH. Yeah, the differentials are.
TDG can it present with cerebellar hypoplasia, transaminitis, but this won't be there, right? The diffusion.
Yeah, yeah, the diffusion will not be there. That was the only. I think it's the typically it should not be there.
And that will be odd for late onset because NKH late onset is a definite possibility, but transaminitis So that can all fit into. That's what the diagnosis and the differential diagnosis was given to us, late onset NKH as a strong possibility.
Will that have similar skin changes, Dr. Rubin?
No, skin changes was all.
I think the PCH is kind of, the differentials are very wide. It can be anything. I don't know if Aigen wants to comment upon that, but the main findings here were the symmetrical changes, which is not commonly seen in the typical PCH variants. So looking at something which binds this one, these changes and the skin changes, and obviously the liver abnormalities.
I don't have a good suggestion, to be honest. For NKH, I would still expect some seizure activity. Biotinidase you have excluded. PIG-A is an option just from the literature. CLN2 you mentioned. Does that make any skin changes?
No, Aigen, this is just purely radiologically and more the adult age group, I guess.
No, this is not CLN. This is CL, chloride channel. CL,
Yes, I understand.
Yeah, CLCN.
Yeah.
Still the skin changes were not.
So
is phenylketonuria possibility? The skin changes.
TMS will pick it.
Okay.
Yeah.
So I guess we have to send it for a whole exome. Okay.
Yeah, we have sent. I'll give a feedback. Cryo has been sent.
All right. All right.
So,
next case.
Right.
Yeah.
So there's a mention by Surbhi about why not LCH or familial HLH.
The imaging won't match, at least that radiologically I can say. Yeah. The other findings I'll leave it to.
Like ferritin is not that high though. That can be due to any liver dysfunction, 700. I'm not sure in familial HLH, it must be much more, something like thousands. But I'm not sure. I need to. Ferritin could be explained by liver dysfunction. Alpha fetoprotein was normal. So this is a 6-year-old boy who came 6 weeks back. So this is one of my colleagues' patient. Father had come just with the reports. I haven't met the child myself, so it's more by the things he told me and the images which I had of MRI. So 6-year-old boy who 6 weeks back. Say, आवाज बंद कर. Sorry. Can you hear me?
Yeah.
6-year-old boy, 6 weeks back, he had high fever. And at the time, he was mildly encephalopathic and he had frequent right focal brief seizure, cluster of seizures, needing 3 anti-seizure medications. And at the time, MRI was done. CSF had shown 17 cells and protein was 35. And that MRI, which father showed to me, the first one, which was 6 weeks back, to me, it had more changes suggested of ADEM and some post-ictal changes due to the seizures. He also had a CSF HSV PCR, which was negative. Neurologist's opinion was taken and they felt this was all knitting into a viral meningoencephalitis. So immunomodulation was not done. And the child was sent home on oral phenytoin and phenobarbital. So that was after 10 days of hospital stay once he recovered. And he was nearly back to his baseline within 5 to 7 days. Then 15 to 20 days into the illness, which is 4 weeks back, he developed again high-grade fever. So this was the first MRI, which was done on day 3, day 4 of illness, right? So this is the first illness. So high fever, seizure, encephalopathic, this MRI thought to be viral meningoencephalitis, sent home after treating symptomatically on phenobarb and phenytoin. So 5-7 days after discharge, he had high fever and he had rash all over his body. and he developed multiple lymph nodes, and through the neck and inguinal region, and he became again Parkinsonian. So he decreased facial expression, sort of rigidity, and then he was readmitted to the hospital where he was initially admitted. And this time he had a, so they were not sure what could be the reason. They continued with the phenytoin and the phenobarb, and then they did a lymph node biopsy, which was mentioned as Kikuchi syndrome in the lymph node biopsy. And he also had bulbar weakness. A second MRI was done now in this admission. Even though after 5-6 days of admission, because the rash was progressing, they stopped phenytoin and phenobarbital and started him on levetiracetam. He was not having seizure this time in the second admission, but because he had this history of frequent seizure a few weeks back, they continued on levetiracetam, and he was given methylpred pulse this time. And after that, in the last few days, the rash has disappeared. He's getting better, though he's still Parkinsonian, and he's been started on Syndopa as well. So this is the second MRI, which Nihaal will show.
Was the CSF PCR sent, Dr. Ved, after the first scan for the viral, any viral organisms?
Yeah, HSV it was sent, which was negative, just HSV.
Yes, HSV. Okay, because the MRI doesn't look typically of HSV, more multifocal. Yeah. All right. So follow-up MRI. Now we have.
And sorry, he also had EBV done, which was negative. EBV, okay. IgM in blood in the second admission.
In the second, okay. The first one had multifocal lesions predominantly along the cortex and some area of restricted diffusion, but the deep brain nuclei were relatively spared. But on the second MRI, you can appreciate that there is again some cortical involvement, some area of restricted diffusion over there. But now the changes are more predominantly in the deep brain nuclei involving the dorsal striatum, demonstrating restricted diffusion. You can appreciate again the edematous changes on the flare sequences. The external capsule also is involved, the anti-limbofunnel capsule also involved, and some degree of patchy edematous changes in the brainstem, the pons, and the medulla. T2-weighted sequences again demonstrate the edematous changes, now predominantly in the bilateral basal ganglia, slightly asymmetrical, right more than left. But yeah, and there was no contrast enhancement, and then I can say that there was no hemorrhagic components or calcific components in these regions. So given the entire course, thinking of viral meningoencephalitis as the first primary, MOG could be a possibility. I don't think if MOG was tested or not on the first scan. On the
MOG is negative. MOG is negative.
And autoimmune, I don't think an autoimmune panel was sent for.
No, just MOG. MOG is.
All right. Yeah. So. Yeah, thinking infection and inflammatory demyelinating conditions. So, if there are any other comments for these, for the cases and
it's just it looks odd to me. It looks as if he had a reaction to phenytoin, or pseudolymphoma sort of presentation is seen with carbamazepine, maybe phenytoin, and maybe those are all immune complex mediated diseases, and in the brain also he had the same manifestation to it, which have not been sort of, patients might not have been imaged before for the brain. Maybe he had a very severe reaction because the child gets better, goes home on phenytoin, and within few days fever with a rash, allergic rash. And then he deteriorates with lymph nodes, a negative EBV. And he's not leukemic, so yeah. His ferritin was around 700, was not in thousands. So that was also.
Yeah, and typically it doesn't look like an HLH variant at least. Yeah.
The clinical situation is improving. Am I getting your point correct?
Yes, it is improving after methylpred pulse was given in this admission and stopping the anti-seizure medicine he was on before. But he's not back to normal, but he's sort of improving.
It may need more time.
Yeah.
I think phenytoin side effect is a good option.
Yeah, it's just so interesting that phenytoin can cause so much in the brain also, the immune reaction. So that's something we could consider in future as well. That's it. because we never think of phenytoin as a
Phenytoin, yeah,
culprit.
yeah.
Yeah.
Mm.
But here it
I
is
think that
so, yeah.
because of the lymph node enlargement, maybe that is another helpful marker. Do they
Yeah.
enlarge based on phenytoin? I think as a
Like
side effect.
carbamazepine I could find, and there were 1 or 2 case reports on phenytoin as well, but they are sort of, they should do because they both have similar sort of side effects. But no MRI changes I could find.
I mean, we didn't do a neck. I don't think we have a neck sequence. I mean, for the
No,
MR,
no.
if an ultrasound was done or not.
Yeah, there were big lymph nodes. They had to biopsy there.
And biopsy is inflammatory, not lymphoma,
Yeah,
not
so it
leukemia.
says Kikuchi syndrome, which is again a
Okay.
very, just tells. Yeah.
Okay, so Kikuchi, I'm thinking is necrotizing lymphadenitis.
Yeah, yeah.
Interesting. All right. Yeah. Thanks for today. Yeah. Over to Pune. Krishnapriya, if you're there.
Yes, sir. Good evening. This is about a 12-year-old girl who presented with history of hemiplegic cerebral palsy. There was history of not crying at birth with global developmental delay, and now she is 12 years, she has caught up. There was history of a single unprovoked seizure at 2 years. On examination, it is an alert child with short stature and microcephaly. She has normal dentition, and there are features of spastic quadriplegia, right side more affected than the left side. She did not have any cleft lip or palate. She had scoliosis and fixed contractures. Yeah, and an MRI was done as part of evaluation for a surgery.
Okay. So I have two sets of MRI because both the sequences are, I mean, both the changes are same. I have put in the second MRI at 12 years of age. You can appreciate that there is a degree of holoprosencephaly over there. You can see that there are the posterior frontal regions, the parietal lobes are, there's no separation over there. Coming down more posteriorly, you can see the ventricles are dysplastic. There is some degree of gray matter heterotopia along the posterior aspect. The septum pellucidum is hypoplastic, giving almost like a box-shaped appearance of the lateral ventricles of the over there. And again, the lateral ventricle is dysplastic, dilated. The temporal horns are again slightly abnormal in morphology. And the parietal sequences, I can only appreciate the genu and the anterior aspect of the body rostrum, but the body of the corpus callosum, the splenium is maybe thinned out, but yeah, the body is definitely not visible. So it's a malformation, it's a midline or ventral induction related abnormality. On the coronal sequences, again, you can appreciate on the lower sequences the appearance of the lateral ventricles, the absence of the septum pellucidum giving these box-shaped appearance. The olfactory system was normal. So the grooves and the nuclei were normal in shape. Again, the dysplasia of the ventricles, temporal horns, again, slightly abnormal in morphology. Posterior fossa, I could not appreciate any abnormalities, at least on these coronal sequences. And then we go back to the 1-year-old child, 1-year scan, and I've just put up the spine sequences. There was some degree of hemivertebrae there along the lower thoracic region. So segmentation anomalies in the lower thoracic vertebrae along with the ventral induction abnormalities. And yeah, I think most of you would have possibly put it out in the chat. Yeah, so the abnormalities of the ventral induction, these are the various abnormalities, and our case fits into the mild interhemispheric variant, which has these remnants of the corpus callosum, at least the genu and the splenium should be present. Posterior frontal regions and parietal lobes are not fused, whereas the more severe gradients, as you can see over there, have more posterior involvement and fusion along the anterior aspects. So our case fits into more closely into the mild interhemispheric variant. Different pathologies can be, or the causative factors can be environmental factors, genetic factors. I'll not go into detail, but yes, these are the various possibilities which can cause these abnormalities. So Krishnapriya, do you have a diagnosis or was genetic sent or on the way or planning to send?
Genetic has not been sent. I have a picture of the child. She does not have much dysmorphism. But microcephaly is there, and the dentition is normal, even though a central single incisor is mentioned along with this in MIH variant. This child does not have that much of dysmorphism at all.
Planning to send, or what's the plan?
Yeah, financial issues are there. We will try to send. Yeah.
Okay. Yeah. If anyone
Thank
wants to
you.
comment upon anything else.
Can I make two comments? Just as a
Yeah, I can.
repetition, perhaps not complete. An absent septum is seen in holoprosencephaly, in rhombencephalosynapsis, in schizencephaly, in severe hydrocephalus, and can be an isolated finding. So you have several options just looking from an absent septum. And in that list here now, you could add another rare variant of holoprosencephaly, which is called septopreoptic holoprosencephaly, which has changes just in the area of the hypothalamus and the optic pathway, and these patients often have hypernatremia, high sodium.
Got it. I agree. Thanks again. Okay, there's what is the name of the entity? I saw. Do you mean the septopreoptic holoprosencephaly? Is that what? Yeah.
It's called septopreoptic.
Yeah. Okay. Thanks again. We'll move on to. Okay, let me see if someone has. Yeah, so that's right. Yeah. We'll move on to our next case from Belgaum. Dr. Kamte or Akshata, you want to take it up? Yeah.
Yes, sir. Good evening, everyone. I'll be presenting a case. A 7-year-old female child came with nocturnal left versive clonic focal seizures. First episode was for 20 to 30 minutes, and later seizures were 3 to 5 minutes. And she had totally 4 episodes in 4 months. Birth history wise, she was full-term born, and LSUS was done due to breech presentation. And she cried immediately after birth and no NICU admission. Development-wise, she had slight developmental delay. And on examination, she had microcephaly and no other neurocutaneous markers and no focal neurological deficits. And we did EEG and MRI as a part of evaluation. EEG is suggestive of right more than left epileptiform discharges. And MRI showed T2 and flare wide matter hyperintensity.
Yeah. I'll show the MRI. So
Yes,
just
sir.
to confirm, no antenatal abnormalities, risk factors, maternal or
No,
fetal.
No, sir.
Okay. And no hemiplegia, hemiparesis, congenital.
No, sir. No
nothing.
focal. No
No
focal
handedness.
neurology. She's right-handed, sir.
Okay. All right.
Yes.
So MRI done at the age of 7 years. Is that right? Most recent one.
Yes, sir. Yes, sir.
Yeah. Okay. So right side you have these hyperintensities or glycosis over there with reduced white matter volume, frontal lobes, and you can have these exact dilatation of the ipsilateral ventricle. There's some degree of volume loss or valvular degeneration going along the corticospinal tracts. If you track it below, you can see that the ipsilateral midbrain also is demonstrating volume loss. So there is valvular degeneration. There's glycosis on the right side, the right periventricular, deep white matter, the frontal region, temporal lobes, and also some degree of glycosis around the pulmonary thalamic nuclei over there. There is generalized cortical volume reduction, possibly slightly more on the right side, if you see on that second image, and valvular degeneration across the lateral corticospinal tract. So there, cerebellum, I could not appreciate any other findings. I could not appreciate any structural malformations. Diffusion, there was no acute abnormality. And on the SWA or the GRE sequence, I could appreciate this focal area of hemosiderin, possibly hemosiderin deposition along the right lateral ventricle. You can appreciate there on the third image. And on the sagittal images, there was some thinning of the corpus callosum, especially in the segment of the body. there was question of and also check the subcutaneous fat on the scalp. There was no deficiency, so no any several lesions. And then I think it was commented as PVL mimic. The presentation here is slightly more only on the right side, not on the other side. So I'm not sure if we can term it as a PVL, but these are some differentials which can be sort of for the slightly asymmetrical involvement. Collagen vascular disorders can have the hemosiderin or calcification associated with it, and some porencephalic or cyanocephalic abnormalities of the ventricles. No neurocutaneous markers, so I think we can maybe the incontinentia pigmenti type lesions can be even less on the differentials. Acquired causes can also cause these unilateral involvement. So yeah, these are the ones which you're thinking of, and I'll open the case if there are any further comments.
Common things are more common. I think this is a residual change. It was mentioned in the chat also in terms of asymmetrical or unilateral PVL with involvement of one hemisphere. The hemisphere is smaller, you have asymmetry in the brainstem, and subsequently you have a kind of a stable course. For Rasmussen, I would expect more dynamic in the clinical setting.
And the epilepsy, would that fit in again?
Sorry?
The epilepsy, the child is having seizures at the moment.
Okay.
Anything to explain that, Dr. Kamte? Or
the child did not have any respiratory seizures. So that was going against Rasmussen's. She came first time at the age of 7 years to us with seizures. And when we did imaging, this was the MRI. The development was also normal for this child. And the birth history was also totally normal. So we also didn't know like how to proceed further. So we wanted to know like, should we do any further initiation for this child?
it's an old ischemic change, but I'm not able to find out what could be the possibility. Rasmussen is completely out. HHE is there's no hemiplegia. So only thing I thought was collagen vascular because of the hemosiderin, but again that can be also seen in acquired causes.
Okay.
The only one which matches was collagen vascular, but yeah.
Collagen, okay, fine. I think we'll do the workup for that then.
Okay.
Thank you.
All right, Dr. Ek, over to you again. Sorry, I think the previous case was from Dr. Rakesh. I think I put out this one by mistake. Dr. Ek, are you there?
Yeah. Sorry, I'm there. So this again is one of my colleagues, Dr. Rakesh Sharma's patient. So he's not there. So I will, because I know the history, I haven't met the family, but I'll just go through what I know. So he's a 4-month-old baby who came to a hospital around 2 weeks back. He had a normal birth, normal development till 2 weeks back when he had this illness, where suddenly for 2 days he was having multiple brief seizure episodes. What family describes looks like seizures with uprolling, eyes going uprolling, baby becoming hypomotor with behavioral arrest multiple times, for which they got the child admitted to a local hospital in drowsiness, where he was treated for the seizures. We don't have any videos of that time. It's all the history. And there was history of fever for a day, which was again undocumented prior to this event. And during the hospital stay, he had SVT with heart rate more than 300 with hypotension, which again was managed with digoxin and didn't require any ventilation, and that improved. But after 5 days of hospital stay, he started to again have right focal seizure and 2 episodes of right focal seizure after 5 days of hospital stay. And he had hemidystonia of the right side, and hence he was sent to our hospital. And when he was admitted with my colleague, Dr. Rakesh, his initial bloods were normal. because this all happened after a febrile illness. CSF was also done, which was normal protein, no cells. Interestingly, his admission platelets were low, 60,000, which improved to 1 lakh prior to discharge. And he also had liver dysfunction at admission with us, mild liver dysfunction, 150 and 140 of OTPT. On examination, child did not have any neurocutaneous markers. He at this time when he came to us, he was more encephalopathic because of all what had happened over 7-10 days. He did have, and he had a normal head size, though his fontanelle was small. But clinically looking at it, he didn't appear to be a baby who had any, no failure to thrive, no skin issues. So this looked more like an acute illness from the history. But with the MRI, we could not knit everything into one, picture, and especially with the history of one female sibling who passed away at 6 weeks age. Again, cause is not known. The child has 4 siblings who are alive and well, female children. So acute onset illness, yeah.
Yeah, so MRI also, I think, done in the acute stage.
It was done after 7 days. So 7 days of SVT.
Okay. Yeah. So I have the T2s. I have extensive involvement of the bilateral hemispheres, cortical involvement, white matter involvement, deep brain nuclei involvement, predominantly involving the frontal temporal lobes over there. Again, bilateral involvement, slightly asymmetrical along the deep brain nuclei. There is also some degree of volume loss, particularly on the cerebellum. You can see that the folia is slightly more prominent. Corpus callosum also demonstrating these hyperintense changes. So corpus callosum involvement also is present. And then on the diffusion wave sequences, we have the radial diffusion. Again, slightly asymmetrical frontal lobe, penicillin regions, temporal lobes over there, predominantly on the left temporal lobe, almost like a wedge-shaped appearance on the left side. The caudate nucleus also demonstrates the radial restricted diffusion. And no hemorrhagic components, no calcification. Contrast was done. Could not appreciate any abnormal contrast uptake. Angio was done. Other than the normal variant of right hypoplastic vertebral artery, the bilateral MCA, ICA were normal. Neck vessels also did not demonstrate any abnormality. I thought there was some degree of optic nerve enhancement on both sides. Then the question I think Dr. Eric was asking is, can this still be related to supraventricular tachycardia? I found only few case reports with imaging, and they usually can have these stroke-like events, but this case had an association of left ICA thrombosis going up to the MCAs. Our case had normal vessels, so I would not be entirely confident to call these purely ischemic lesions. I'm not sure if it fits the HLH variants, but the diffuse extensive involvement in the acute stage can have these cerebrocytotoxic edema. Pulmonary MOG can have these changes. Hypoxia is slightly asymmetrical. Again, not very typical. There's another possibility of I think metabolic or mitochondrial was the question, Dr. Vic. Is that right?
Yes, about mitochondrial. Yeah, there was a possibility. Differential.
Yeah.
To me, it didn't look.
Yeah. And
it's difficult to explain. He had like CSF was normal. HSV PCR has not been done. His cultures are negative. He did not have any fever in the hospital. Only a history of fever for a day. But it is. We didn't do scrub. We didn't do dengue. We didn't do COVID. So whether this was all part of a viral illness which led to him to have all this, and he had myocarditis causing SVT and then secondary changes, I just wondered, because low platelets which improved cannot be explained in a illness from birth. TMS, GCMS have been sent.
This looks more like the acute event causing all these changes rather than something which was there congenitally.
Right.
So with an infective process, explain all the findings.
Again,
something like a viral infection.
Yeah, viral
cytokine storm. Yeah, associated
cytokine storm. Right.
Storm.
Yeah. because yeah, that's what I think it should, because again, that's why I always think, could it be urea cycle defect? Could it be, we also thought on those like metabolic disorder or in such a small child or mitochondrial, but again, those CBC was a clue, the platelet being low, improving, or deranged liver function, which was slightly better prior to discharge. So maybe those subtle clues that this is more of an acute illness rather than from birth. We didn't do IL-6. I wish we had done it initially because we realized too late that this could be, because I think our colleagues were more into metabolic disorder at the start of the illness rather than, I would say IL-6 would have helped if we could have done it in the initial phase. We hadn't done it. Maybe we should do it more often also. Whenever one has this low platelets, liver dysfunction, acute deterioration, like ferritin, maybe IL-6 also should be done. We didn't do ferritin also, so maybe we should have done that.
Nihaal, can you go back to the MR angiogram, which of course is not very sensitive, but is that, if you look at the image on the lower row to the left, is that normal? Or is there
you mean this one?
Yeah.
Yeah, this is, I mean, for the extent of involvement, this is normal. There's hypoplastic right ACOM over there, but that's normal variant, and there's hypoplastic vertebral artery. But the MCAs are normal going up to the cortical branches. The ACAs are normal. The intercalateral arteries are normal. So,
and the lenticular striate vessels?
Well, that would be difficult to appreciate, but but given the involvement is not primarily lenticular striate, it's more extensive involvement. So I would have expected something more significant on the the MRAs. And the other thing, what we thought, if it was primarily infarct, there are cytotoxic edema over there. If it was a single event, or it's a single ischemic foci, but the deep gray nuclei changes, they don't show any restricted diffusion, especially the thalamic regions. The left basal ganglia doesn't show any abnormalities. So only infarcts, I think, it would be one stage rather than having a differential pattern of edema. Hence, was favoring more of an infective process causing with as cytokine storm causing these changes, possibly para-infectious, going into para-infectious too. Dr. lumbar puncture, I think normal mention.
Yeah, lumbar puncture is normal.
For me as a beginner, I have considered first multiple infarcts, but you seem to disagree. Can I be slightly provocative because I'm not an expert in that field? Cytokine storm is a very common term you put into the discussion. If ever you don't know what it is, you say mitochondrial or cytokine storm. This is exaggerated, but you understand perhaps my comment. You will do a follow-up imaging sooner or later?
Yeah, few months time. Something, Nihaal, I wanted to ask in the fifth image, second row, second image, the lower row, second image, you know,
these are the GRE sequences.
Okay. Oh, these are, second one is also GRE. Okay. So because it shows in the lower panel? Lower panel. Second one.
Yeah, these are GRE images.
Second one is GRE as well. Okay.
Yeah, all three are GRE.
Okay, okay. Because they appear to be putamen and thalamic hyperintensity. Yeah.
No. This is GRE. So yeah.
Okay. It's mentioned vasospasm in favor of that.
Yeah, but the arteries don't narrow, they are not narrowed in for vasospasm. Such a significant involvement with almost near normal appearance of the arteries.
This imaging was 1 week after onset, am I correct?
Yes, 1 week.
So you could still, in theory, have some normalization of the vessels within a week.
But that would, the signals are more, within a week, the signals also should have been normalized then, or going into normalization.
Okay.
As I mentioned of embolic infarct, there can be peripheral, but such an extensive involvement of embolic infarcts, I have not seen. So I may be wrong, but spectroscopy, I don't think is required. There is oxidative, it would show a lactate peak. There is anaerobic metabolism over there. Dr. Vivek, treatment? Dr. Sayed,
Treatment was supportive, prevent
Yeah.
seizures, tube feed, and hopefully he'll get better.
Aspirin?
My colleagues, I don't think they gave aspirin. Would you give aspirin? And because angio negative, like looks more para-infectious.
Would you be sending for a panel, PCR panel, complete panel, or
CSF?
yeah?
The yield will be so low because there are no cells.
Okay.
There's no inflammation, no protein.
All right. Let's hope the child.
Is there any old gliosis? Just one thing, because the radiologist felt there was an old gliosis. No.
No, I can't find an old gliosis.
Okay.
There's no focal volume loss for that. Sulcation, the sulci are, even the deep nuclei, the volume is well preserved and symmetrical, so I cannot appreciate any gliosis.
Okay, thank you. Thanks.
Okay, there's a comment from Dr. Lokesh, bilateral simultaneous MCS strokes, post mycoplasma.
Sure. The only problem with mycoplasma is we used to do it so often, maybe not in a 4-month-old, but 1-2-year-old children, and 70% will have positive IgM. So not sure how to prove or disprove it. Mycoplasma often comes positive, the ELISA antibody. So often we assume it is because of that, but there's no sensitive test which tells you that, okay, this is due to mycoplasma.
Okay, all right then. I think we'll move on to our next case. Romit, are you there? Okay, I think Romit isn't available, so we'll discuss his cases for the next time. We'll move on to case number 10. Hina, if you're there, over to you.
Yes, I'm here.
Yeah.
Good evening, everybody. This is a child who's 7 years old, female child, third degree, with a child of third degree consanguineous marriage, and she had an uneventful antenatal and birth history. And as per the parents, her development was normal till 1 year of age, after which she had an episode of fever and diarrhea. And within a span of 10 days, she lost all the milestones she had gained. So initially, before this episode of fever, she was able to walk on her own, walk with some support, minimal support, and she had her speech and all other milestones were within normal range for that age. And then after this episode, she was not even able to sit. And then after that, gradually, she has regained all her milestones. Now she's able to walk on her own. She's able to speak most of the things, but her speech is slightly dysarthric. and she has an ataxia. So after the episode, the parents noticed that her gait has become unstable. When she started walking, she was never able to walk normally. And since then till now, this happened at 1 year of age, and till now, she has slowly gained her milestones, and she has not worsened over the span of last 6 years. And on examination, she has a normal head circumference for age. There are no neurocutaneous markers, no apparent facial dysmorphism as such. Even though her extraocular muscle movements are full, she has slow saccades and dysarthric speech, and she has exaggerated reflexes on both sides, and cerebral signs are positive along with ataxia. So I would say it is kind of a non-progressive ataxia because she has remained stable the last 7 years, 6 years.
All right.
So
Okay. Yeah, I can show
can we
you.
see?
Yeah, so I have just selected images when the child was 1 year old, and the primary abnormalities, as you can see, is in the cerebellum, extensive cerebellar atrophy, possibly the cortex is hyperintense. I don't have a flare with that, but supratemporal brain appeared to be normal, at least on that image. The deep brain nuclei was normal. There's no white matter abnormalities, but predominant cerebellar atrophy with, I think, the cortex is also slightly hyperintense on the T2 sequence is better appreciated on the coronal sequence over there. The spinal cord, at least the cervical and the upper thoracic cord, did not demonstrate any volume loss. Again, the sagittal images, you can appreciate the vermis demonstrating significant atrophic changes, or if hypoplastic based off only one single scan. Yeah. Then we had a follow-up. Follow-up again has selected images, again demonstrating these atrophic changes in the cerebellum. You have a flare sequence over there on the bottle panel, and you can appreciate that there is flare hyperintense cerebellar cortex. And then I think, yeah, genetics was sent.
Yes, sir. So this genetics and everything has been sent 2 years back, and it was a clinical exome that was sent, and it had come positive for VLDR mutation VUS. So my question over here is, this child is having even though she's not having a progressive ataxia, her cerebellar atrophy has progressed over the span of 5 years. So whether or not it fits into, whether the phenotype fits into the gene which we have got positive, or whether we should be investigating further.
Yeah, so the gene over there has these typical MRI changes, a non-lobulated or incomplete lobulated vermis, hypoplasia of the brainstem and the vermis, and also it can have corpuscular abnormalities, but predominant changes in the supratemporal brain in terms of lissencephaly or pachygyria. All of these changes, except the reduced volume or height was not there in our child. There was no supratemporal malformation, and the vermis also was lobulated, though atrophic. So it doesn't fit. I think I would confidently say that it doesn't fit into the gene, which is of the uncertain significance. Based on the imaging, I think IGAN will take over, but these are various differentials of the cerebellar atrophy with cerebellar cortex hyperintensities. Yeah, you can read these 2 review papers and maybe send for a whole exome or selective assessment of these differentials. I'll open the case.
Another question which I have, sir, is
Yeah.
that mitochondrial disorders, complex 1 deficiency, which has been mentioned here, can it no basal ganglia or brainstem involvement and only progressive cerebral atrophy with flare changes, I mean flare hyperintensities, as in our case? Well, whether mitochondrial can present this way, only with progressive cerebellar atrophy.
What we have seen, I think, you have not demonstrated any progression. You have demonstrated a residual change after one kind of hit at the age of 1 year. And you have a stable clinical situation, you said, no regression. So I think
yes, sir.
mitochondrial or genetic or Lewy Bowyer syndrome is very unlikely. And as Nihaal said, and I mean, this residual option was also mentioned in the chat, I fully agree. And the option of a very low density lipoprotein receptor that this is not, is definitely ruled out because the image is completely different. And you can have cerebellar cortex hyperintensity in static, in residual, in progressive condition. It doesn't really help here now. So my guess is this is residual. I would not even send, well, it's a matter of whether you can afford it or what you expect. The chance that you have, that you learn something from exome sequencing is very low. You may get confused by an incidental genetic finding, but this is mainly residual.
So I had
Okay,
two
sir.
patients in the first year, 1 year, 1.5 years, same diarrhea, vomiting, cereballitis, and then residual illness, and then they sort of static course. It's just surprising that in the first 2 years, maybe they have slightly different sort of cereballitis present. It's much worse than a cereballitis in a 5 to 10-year-old where they recover better. I don't know why, because these ones who have it at the age of 1, they continue to have problems. And I've seen it twice with gastroenteritis, which has not really been mentioned as much associated with cereballitis.
So this probably was some kind, just one hit which happened at 1 year, and now since a child is stable, we should consider this as an acquired cause of the cerebellar atrophy.
Very
Looks
likely,
like.
very likely.
Okay, sir. Thank you
Yep.
so much, everybody. That was really helpful.
Okay, thanks, Hina. And I'll
Sir.
end up with a follow-up case. This was discussed the last time. Anas, if you're there, quickly summarize the clinical presentation.
Yeah. So the 3-year-old boy, born to non-consanguineous parents, third in birth order, developed normal premorbidly. He started to have behavioral changes in the form of excessive fear, shyness, and hallucination for 2 days, followed by eye movements, restriction in all direction. Same night, he had the right focal clonic seizure, which got controlled after admission. So he was admitted elsewhere initially. 2 days later after admission, he had another focal status, after which he regressed cognitively and in all domains actually. He received initial suspicion was of autoimmune, so he received IVIG, IV methylprednisolone, rituximab, cyclophosphamide, MMF, and he showed no response in the regression part, but his seizures had controlled. Later, he developed dystonia in hospital and later had hyperthermia, which only responded to bromocriptine. And later started to have, then he got discharged. Post-discharge, he started to have myoclonic jerks, for which he came to us. This had started for 15 days or so. By the time he had come to us, he almost had myoclonic jerks daily. This is the MRI.
Okay, so this is the initial MRIs, predominant changes in the parietal thalami, left more than right. Some area of restricted diffusion in the left parietal lobe, the cortex over there. Yeah, so the main changes were the thalamic changes and the left parietal lobe abnormalities.
Workup for autoimmune and was negative. MOG and everything, GAD was normal. TMS, GCMS was normal as well. In view of the, poor response to, to immunomodulation and the myoclonic jerks which were persistent, whole exome sequencing was done, suspecting Paul-G kind of variant because of the bilateral thalamic changes.
Yeah,
as well as
then,
progressive myoclonus.
Yeah, we had a follow-up scan and there was some possibly some new areas of restricted diffusion, at least on the opposite side over there in the right medial occipital lobe, the perisylvian region next to the ipsilateral cortex on the left side. There were some pulvinar thalamic changes possibly related to the seizures. Yeah, again, the prayer sequences, now we have bilateral bithalamic involvement, more uniform than compared to the previous studies. There is a degree of volume loss. Again, the T2s, you can better appreciate the area, the degree of volume loss, neurodegeneration, bithalamic hyperintensities. Yeah, then we thought of, as Anas mentioned, the possibility of Paul-G. Then we discussed the possibility, and the last time Paul-G was possibility, given that some the imaging findings were matching what was mentioned in literature. Autoimmune was the other consideration initially. And then asked on the genetics.
So, as per genetics, we got a, heterozygous variation in the POLG gene. So, thing is, the clinical findings are more like homozygous, but the mutation what came was heterozygous. So, it still could be a possibility autosomal recessive, autosomal dominant variant. This is where we are right now. Though the clinical, I mean, clinically, as the radiologically and clinically, the POLG is fitting. The external ophthalmoplegia what he had, and the sun regression, and the persistent myoclonic jerks that he's having right now. So parental segregation has been sent, and we have called them for nerve conduction and as well. No liver involvement as of now. LFT is normal, so we're following it up as well.
All right, yeah, if anyone wants to come in on the genes or the images or the clinical findings.
Thank
The
you.
heterozygous hit is, yeah, sorry.
You're not okay, go ahead.
Yeah, sorry. The heterozygous hit is usually associated with sort of peripheral neuropathy, progressive external ophthalmoplegia, and slightly slowly progressive illness. Whereas the homozygous hit is associated with Alport phenotype. This child almost has Alport phenotype. He continues to have epilepsy partialis continue of the right hand, which is not subsiding in last 1 month, along with other types of seizures. So that is why we were, if it was a homozygous, it was a full match, but with only one heterozygous pathogenic hit, we are still not sure. So the genetics are still working on it. There's not a full answer as of now. Thank you.
The only thing is the glutamine is terminating, which is very, in the report, GLN 397TER terminates, which often is very important when there is a termination of the protein. So with
it's a single hit. Yeah.
But it's a termination. So is it a dose-related phenomena in POLG2? And if there is termination, maybe that makes it worse than what you see if there was just a point, if there was just a point mutation. So maybe the progressive external ophthalmoplegias might have just a point mutation leading to not a termination, only a missense mutation. While maybe here there is a termination, that's why it might have led to a more severe course. Just a postulation. Because there is a termination, which becomes very important.
Yeah, so that's what the genetics team has not come up with a clear answer to correlate with this. So we're still looking for any other hit, whether we need to do other forms of testing. After the parental segregation comes, they said they will come back.
Yeah.
Would you think of SSP, or would you consider SSP? It doesn't look like it. EEG doesn't show.
No, EEG as of now. No. Yeah, go ahead, Anna.
Yeah, EEG was not suggestive of SSP as of now. So we've done it a couple of times. It was done outside as well. So anyway, we are following it up, and that is also a remote possibility that's been still considered. But again, the imaging, I think maybe is not suggestive of SSP.
Not the typical one, but yeah, thalamic involvement can be seen in some cases of SSP.
SSP is a great mimic. It can present like, that's the problem. But EEG usually should show by now.
All right, we'll get back to you with the parental segregation analysis then. Yeah. So yeah, that's our last case. So yeah, thanks once again for the participation of the panelists and the attendees. We'll meet again on the 1st of September. Kindly send in your cases by the 30th of August. You can email me or any one of us on the chat. And we'll see you again in 2 weeks' time.